Ureters, these are a pair of thick walled mucomuscular tubes which convey urine from the kidney to the bladder. The peristaltic movements which are created in the minor calyces here are responsible for the movement or transport of urine. So length of this ureter will be around 25 centimeters and diameter will be only 3 mm. So communications, superiorly it communicates with this flask shaped renal pelvis, inferiorly it opens into the urinary bladder. Parts of the ureter. There are 3 parts for the ureter. So this part is called from here to here abdominal part. And then pelvic part, till here abdominal part, then pelvic part, then intravesical part. So remaining is the intravesical part. So this is the summary of ureter. So it has 3 parts: abdominal part, pelvic part and intravesical part. Abdominal part is inside the abdominal cavity. Pelvic part after entering into the greater pelvis and into the lesser pelvis. Then intravesical in the wall of the urinary bladder. Then there are constrictions, 5 constrictions. So we will learn about them. Then blood supply. Blood supply will be from many branches throughout its course in the abdomen as well as pelvis, and lymphatics will be lateral aortic, common iliac and internal iliac lymph nodes. So aortic and iliac lymph nodes, common iliac and internal iliac. Sympathetic supply will be the nerve supply from T10 and T11, and parasympathetics will be from S2 to S4. So you can see the various constrictions here. So first constriction will be at the pelviureteric junction. So where the pelvis is continuing as the ureter, this is the first site of constriction. Then second constriction is when it enters the greater pelvis, that is at the pelvic brim. Then third constriction is inside the pelvis, lesser pelvis, it is crossed by the ductus deferens or vas deferens. So this is the third constriction. Because of the crossing it causes. Fourth one is when it enters into the bladder. So it is oblique. So this acts as fourth constriction. And finally when it opens into the urinary bladder, cavity of the urinary bladder, that will be the fifth constriction. So these are the various constrictions of the urinary bladder. Then course, you can see the course here in this diagram. So course of the urinary bladder. So initially after beginning from the renal pelvis, it runs downwards on the psoas major muscle, where it is crossed by these gonadal vessels on both sides. So then it crosses the bifurcation of common iliac arteries, then enters the greater pelvis along the anterior border of greater sciatic notch. So this is the anterior border of greater sciatic notch. Then it crosses the ischial spine and then it enters into the urinary bladder. So here it runs downwards and here it runs downwards and laterally while entering into the pelvis. So after entering the pelvis, it runs again medially to open into the bladder. So this is the course. It passes downwards and slightly medially on the psoas major muscle. So this muscle will be in front of lumbar vertebra. and it enters the true pelvic cavity, bifurcation of common iliac arteries at the pelvic brim. So it is entering into the true pelvic cavity. Then after entering the pelvis, it runs downwards, backwards and laterally along the greater sciatic notch and the ischial spine as shown below before, and then turns medially to reach the base of the bladder. Then in the wall of the urinary bladder, it runs obliquely and opens into the bladder. So this is about few points about the course of the urinary bladder. So you can see here how it is entering the lesser pelvis, and first crosses the greater pelvis, then lesser pelvis, and then along the anterior margin of greater sciatic notch, then ischial spine, and then running medially towards the urinary bladder. Then so what are the factors which help in the preventing the reflux of the urine? So first of all, it enters the bladder oblique direction. So this helps like a flap valve action. It acts as a flap valve. The muscle acts as a flap valve and prevents backward flow, and the peristalsis is running downwards from the ureteric muscle. So this also helps in only downward movement of the urine. And then low pressure in the low urinary bladder. This helps in preventing backward flow of urine. So here you can see from the abdominal aorta, so this is the renal artery. So blood supply is from renal artery, so first one, and then gonadal artery, second one. So you can see it is crossing along the gonadal vessels, then lumbar arteries, then from the common iliac arteries there are direct branches, and then from internal iliac also there are direct branches. So this include the vesical artery, uterine artery and vaginal artery. Even uterine and vaginal arteries also supplying the bladder, and vesical artery, superior vesical and inferior vesical arteries. So they supply the bladder. So while they are supplying the bladder, so they also supply the ureter. So what are the applied aspects? So here there are some developmental anomalies of the ureter. First one is ectopic ureter. That means so the ureter has to open into the urinary bladder. In spite of the urinary bladder, it may open somewhere into the prostatic urethra or seminal vesicles or into the rectum or other than normal part, that is lower part of the bladder. And in females you can see it's opening into urethra, vagina and vestibule sometimes, and very rarely rectum also. So this is called ectopic ureter. And ureteric obstruction, so any stones in the renal calculus may fall into the ureter and obstruct the ureter. So then urine can't enter into the distal part of the ureter or into the bladder, and it leads to dilatation of the ureter, that is called hydroureter. And postcaval ureter, right ureter hooks around the left side of inferior vena cava. So this is called postcaval ureter. This also may cause ureteric obstruction. So first one is ectopic ureter, second one is ureteric obstruction. Duplication of the ureter. So you can see the duplication here. So there are two ureters. So from the renal pelvis, there are two renal pelvis may be present, or single renal pelvis may form the two ureters, or two renal pelvis joining to form one ureter. So this is partial duplication and this is complete duplication. So you can see here at hydroureter and undeveloped ureter. This is blind ureter. So ureteric bud, it has to reach the renal metanephros here. So this is incomplete, so it leads to blind ureter. Then ureteric colic. So any stone inside the ureter or some other causes of dilatation of the ureter, obstruction of the ureter, it leads to pain. So it is mainly referred pain, mainly refers to the loin. So length is very long from abdomen to the pelvis. So pain may be referred from the loin to the infraumbilical part of the abdomen and even to the groin also. So ureteric peristalsis is nothing but contraction wave produced by the pelvis. So calyces, minor calyces that proceeds towards the urinary bladder. So this is the ureteric peristalsis. Pressure within the ureter at the time of each peristalsis will be 20 to 80 centimeters. So renal stones, this is the common thing we have seen. In so many people we will see the renal stones due to dehydration. Then what is lithotripsy? Litho means stone, tripsy, breaking, destruction of renal stones is called lithotripsy. Usually it is performed by extracorporeal shockwave therapy. Extracorporeal shockwave therapy. So this procedure uses high intensity acoustic pulse to break the stones. And it may be used for bile stones also anyway. In laser lithotripsy, so you will use laser light, so that is emitted from the cystoscope. Cysto means bladder, a scope passing through the bladder to enter into the ureter, or it is also called ureteroscope to break the stones. So laser light is introduced through this ureteroscope to break the stones. So this is called laser lithotripsy. Sometimes surgical intervention is also required, and patients may be treated with surgical approach. So any time while during any surgeries also, excessive mobilization of ureter, it causes avascular necrosis. So excessive mobilization, you shouldn't move the ureter much. It is fixed with connective tissue to the posterior abdominal wall, so it should be fixed. So this excessive mobilization may cause necrosis. So visualization of ureter, you can see normally in ultrasound, we can take a CT scan, MRI, ureteroscopy can be done, or pylography, that is injection of radioactive fluid through cystoscopy or ureteroscopy into the urinary tract and taking a X-ray. So this is called pylography. And there are two types of pylography. One is intravenous pylography. So we introduce the dye into the blood, so that gets filtered in the renal system, and you can see the flow in the kidney, and you can see the patency or obstruction anywhere in the urinary tract. Another one is retrograde or ascending pylography, which we do through the ascending cystoscopy. So dye injected directly into the ureter through the cystoscope or ureteric catheter. So these are the things about ureter.